Well, good afternoon, and actually evening, ladies and gentlemen, and welcome to the first translational medicine webinar for the Blue Rose series, where we talk about science-based tools for the clinical practice. I am Chris Jooste. I'm a geneticist and general scientist there at Blue Rose Biotech and Slate, and I have a little minor role there at the Pelvic Floor Foundation as well. And speaking of the Pelvic Floor Foundation, tonight we're joined by Professor Stephen Jeffery. Stephen, are you well?
Yeah, thanks very much, Chris. Very exciting times. And this is hopefully the first of many very exciting webinars where we're going to be looking at a broad array of science and how it fits into translational medicine. So it's very great. Absolutely looking forward to tonight as one of the first ones, Chris.
Yeah, absolutely. Because we saw in a lot of the Pelvic Floor Foundation's webinars that topics like epigenetics and genetic testing and obesity and intergenerational risk always comes up. The genetics in general comes up, which is my playing field, but also just translational medicine in general. So there's clearly a demand for this type of thing. People want to know more. All right. So we
So,
figured,
Chris,
yeah,
yeah, from the
yeah,
bat, I can see we've got quite a lot of, we've got a lot of clinicians online already.
yeah.
What for those of us who maybe grew up when genetics was that horrible subject with lots of little drawings of little squares and dots and things, little strands, and we try to get through it in the middle of the night in second year medicine. What is translational medicine as
Yeah.
such?
So it's
What is
interesting
that?
that you say that. So even for the geneticist, genetics is that horrible subject that keeps you up in the middle of the night. But yeah, so translational medicine in a nutshell is basically taking clinical or scientific based tools and concepts, and then applying them to a clinical setting. So it's in layman's terms, it's the natural application of the theory. So kind of how a mechanic or an engineer employs the theory of physics, a translational medical approach would be to take that's written in the textbook that the scientists are doing behind the scenes in the lab, and then applying that to the medical setting and actually help cure people and treat people and that type of thing.
Okay.
Yeah.
Yeah, and I think the whole purpose of tonight is, well, the first one of tonight, but going forward, we're going to be making this a regular session. But to really bridge that interface between us clinicians who are sitting with patients every day, but not really understanding what's happening at the level of the science, and to see if we can bridge that gap and potentially make it make us better clinicians because we understand what you guys can offer, and also for you guys to understand what we need, because I think often you guys want to throw a whole lot of tests at us, but I mean we don't need all of them. So
Yeah,
I mean that's
absolutely. Absolutely. And that's
yeah.
actually a big topic of tonight is, well, when do you actually order a test? Because I agree 100% is it's not only the clinicians that need to hear from the scientists, but also the scientists need to get a little bit of a practical perspective of what's important. So, because yeah, and it really helps to reframe because they're two, actually I say two fields, but it's really all the fields should be speaking to each other much more, and at least we're moving in this more interdisciplinary direction these days. But wow, it's crucial. That's absolutely crucial that we should do that more. Um,
Yeah.
yeah.
Yeah, so just a little bit of housekeeping. So these are run through Blue Rose, which is a company that is basically focused on translational medicine. Chris is spearheading that. And I don't think Chris is going to tell you who he is, but Chris is he's got a master's in genetics, but he's got a very, very deep interest and research background in neuroscience as well. But really spans a lot of aspects of um, science and molecular biology, which are all sort of long words to us clinicians. But his real heart is to, take science and put it into clinical practice, and that's what the whole driver of today is. Chris is working for the foundation, and he's helping us with some of our research as well, and dealing with our academic staff in Amsterdam on a day-to-day basis in working on some of our other projects in our sort of our basic science projects. So Chris does have a broad background in other scientific aspects as well. So we're looking forward to that. In keeping with how we have done some of our other webinars, we really want to make this interactive. We don't want to be tied to PowerPoint slides for this specific webinar. And as you can see, there's a chat button, there's a Q&A. Let's stick to the Q&A button, and you can sort of fire away with your questions along the way. We really do welcome questions. Are you happy with that, Chris?
Absolutely. Anytime, interrupt as much as possible. Yeah.
So we'll be keeping a good eye on that Q&A. Give us your comments, and as I say, it's great to have quite a number of clinicians that I do recognize on the webinar tonight. So, Chris, so where do we actually, where do we fit in? I mean, we are sometimes a little bit scared. We got peripheral to a lot of the tests that you're suggesting. I mean, even some of that stuff that you had on the sort of blurb of tonight's webinar were kind of foreign concepts to us.
Yeah. Yeah. So that's
And
why I thought,
you want to pull us into the soul.
yeah. Yeah. So I thought a great place to start would be with genetic screening, right? As opposed to genetic testing. And I'll talk a little bit about what the distinction is later, but I think any clinician knows screening. That's a very common thing that a clinician deals with. So we'll talk a little bit about when should someone actually think the flags and the light should go on. Okay, this is genetics or genetic related. Uh, and we'll look a little bit at from there which type of tests there are and which type of tests are worth ordering. And then also how to not, like you said, over test and be thrown with all of these unnecessary tests and just cause anxiety and that type of thing. So I think a good place to start in terms of that would actually be to look at the case of when is something monogenic, right? So one gene has an effect. Um, and how do you choose between screening panels, single gene tests, and whole exome or whole genome sequencing, which is another interesting thing that
That's
we'll
it.
talk.
Um,
Yeah, yeah, yeah. Go.
Thanks. Yeah, I mean, looking forward to hearing all that. And already, some of us are maybe starting to get a little bit blown away by some of the terminology. But as clinicians, we often are quite scared of screens because, it's not one thing to do a test, but I think maybe we get a bit nervous as to what to do, with the result. So it's all very easy, and patients are very interested in screening themselves. So they do come
Oh
to
yeah.
us with that.
Absolutely. And especially in this modern era when people come to you with their cell phone and they said, especially with genetic screening, where they say, look, I did this test that I found online and it says here that I'm at risk for this and that. And so then you as a clinician sit there and you think, well, what do I say to this patient who did their own test and came to me with a test, you know?
But yeah, but as you say, I mean, and I'm looking forward to hearing about the mechanics of the whole thing. But I think we're are very interested, and personally, I'm talking to Chris extensively over the last few months about a lot of this. There's a lot that we can offer our patients if we know about their genetics, and so that really is the interest here. We
Yeah.
can get under the hood. It's, in my opinion, it's like taking your modern BMW or Mercedes to a shop, and now they plug it in and they'll tell you what's wrong with it. Where in the past they used to tinker around with a spanner and tell you what is wrong. So, and I think that's really where we are in modern medicine, and that is exactly what's driving how we're thinking about genetics and these new webinars. So, but Chris, sorry to interrupt. I think you can carry on and tell us about monogenic and
Yeah.
all
No,
aspects of
yeah,
screen.
you're absolutely right. Now, I love the analogy of the BMW that you just plug in. Because yeah, that's a lot, as you know, a lot of medicine, especially if you look at things like psychiatry, it's sort of a shotgun approach where you kind of throw treatments and medications at a person and hope something sticks. And that it becomes screening essentially helps us to define or to determine where to start. And so we don't have a very broad range of sort of poking into the dark. Although I should distinguish that that's actually more on the side of genetic testing. So screening, as a sort of general term, refers to taking a population that is technically healthy, or doesn't have a defined disease, but they might be at risk, and so you you then screen them for, or they might be early onset or But the idea behind the screening is actually to do it proactively or semi-proactively, to identify a risk. And also you want to do that on a something that you can actually do something about clinically as well. It doesn't
Yeah.
help you screen for something that there is no cure or treatment for. Um, so we, as general ethics guidelines, because and we'll talk about that as well. That's the problem with genetic screening is it doesn't just tell you one thing oftentimes, especially if you talk about the bigger tests like the whole genome or exome sequencing, you actually find out a lot. And now if I sit here and I look at your results and I can see, but you're at a very high risk for, let's say, schizophrenia, which is a polygenic or complex disorder. So there's lots of different genes and environmental factors and things involved there. But if I, for as an example, see you are at risk of that, am I obligated to tell you about that? Schizophrenia does have treatment. You have risperidone and clozapine and all sorts of flupentexyl decanoate, all sorts of medications for that as well. But there are diseases that do not have proper screening, and you didn't opt in to hear about that. And above and beyond that, if something has a high heritability, what about your family? Right? Do we tell them as well? Because inevitably, if I do a genetic screening test on you, I'm actually getting information on a whole group of people that are related to you. So these are all the complexities when it comes to the ethics of it as well.
Yeah, and I think it's going to become very important for societies and different groups to start implementing guidelines with
yeah,
screening to really
absolutely.
understand,
Absolutely.
safe screening or ethical screening, and we can't shy away from it because it's there and it can really help patients.
Yeah,
And a lot of people, it's better to know than not to know, and ultimately, with the constant and with the knowledge, we'll hopefully start driving research into prevention and altering the outcome of that actual genetic profile the patient
yeah.
has.
Yeah, I personally, I'm of the opinion that you can't solve a problem if you can't identify the problem. So I want to know. I want to know the all of the information, but not everyone is wired like that. I think, and correct me if I'm wrong, but I think as someone in medicine, you are the same, especially in the surgical field. You see a problem and you want to fix it. So yeah,
Yeah, absolutely. So, I mean, I think what I mean, we will focus a lot on screening tonight, but I mean, I think just in terms of what we can obtain from a genetic test from genetic profile of a patient is a lot more than we previously could, and in one of the next webinars, we'll certainly talk about the pharmacogenomics, where the implementation of a genetic result would dictate and tell us exactly where we should go in terms of our pharmacotherapy of the patients. And I think
yeah.
that's a very exciting aspect. And I think we would potentially do that under one of our webinars quite soon as well in the new year. But I mean, I think that is something that we will cover a lot.
Yeah,
And
that's a
so we know that screening isn't the only role of genetics. I mean,
yeah.
it's dictating therapy now as well.
Yeah, yeah, absolutely. Yeah, I think that's the natural follow-up webinar to screening is pharmacogenomics or precision medicine, where you look at exactly what you just said. But don't give all of the secrets of genetic pharmacogenomics away. We'll keep that for the next for the next webinar. But yeah, that's a topic that's quite close to my heart as well because it's largely what my master's revolved around. So yeah, I'm very excited to talk about that. But on the genetic screening, so there are a couple of screening tests that you should probably be very familiar with, and especially on the gynecological fields. So that would be something like newborn screening, where there's the heel prick test, where they usually look at rare conditions or something that could potentially be a serious condition, and especially once again if there is a treatment for it. We also get the reproductive screening. So if you have the sort of carrier screening type things or parental screening, so NIPT is the most famous example of this. And I'm sure you work a lot with NIPT. Yeah,
Yeah.
it's a big um,
Yeah.
yeah, yeah,
Yeah. So I mean, so these are these. I mean, because we've really rolled this out to our pelvic floor foundation attendees in a big way. A lot of the people who are on tonight are in the world of obstetrics and gynecology. And so, in terms of screening, the heel prick, is that something that is done routinely in many hospitals, or is it? I mean, I think someone did, I think, offer our kids something. Might not have done it and not found anything, but how is that actually rolled out on a day-to-day basis in day-to-day clinical practice?
Depends on depends on the hospital, depends on private or public, depends on the country. So there are many variables. Uh, Here in private practice in South Africa, people do tend to offer heel prick tests, but yeah, that changes. That changes. There is no uniform um, way that the hospitals do it necessarily. But as a common rule of thumb, there are the routine tests, and that would be one of them. But usually only if there's a reason to believe that there might be a serious underlying sort of condition. So they wouldn't, yeah, in some places it's not routine. And actually think that it should be routine because a lot of these tests are not particularly expensive. There's already a list of other routine tests that everyone does. And it's worth getting these answers, especially if
What
it's, yeah.
I mean, just on that point, what would you consider to be the ideal genetic test for a newborn? A baby's born completely normal, on examination, normal, everything was normal antenatally, including all the screenings.
Yeah.
What would you want to know about that specific baby that might affect its long-term health?
So basic things like like allergens, and especially medically related allergens, and penicillin resistance, for instance, and that type of thing.
Can you screen for that genetically?
Yeah, there are markers for drug resistance and overactive metabolics and that type of thing of drugs. So, and that once again kind of touches on the pharmacogenomic side of things. So you definitely can screen for when people are going to be either resistant to drugs, or sometimes and quite often more dangerously be what's called an ultra rapid metabolizer. So I can give you one example. So there's a lot of people who over metabolize the drug called warfarin. And what
Yeah.
happens is you give them the standard dose and they over metabolize it and they get central nervous system bleeding. This is something that we can test for with a basic screen. So so that type of thing is just sort of daily adjusted lifestyle type things that essentially just stops this kid from having a lot of unnecessary pain and suffering in their life because we knew from the start, don't give this person this medication or don't do this. And there's a I forget what it is now, but there's a very common antibiotic um, that they give babies, and it causes deafness in I forget what the percentage is, but in a lot of babies. And it's such an easy test that there's absolutely no reason to not just give it to everyone and then save those people from or prevent those people from going deaf because of this antibiotic. So that's
Aminoglycosides are well known to cause deafness. Aminoglycosides, which is gentamicin, something like that. So I don't know if that's what you're talking about, but yeah, absolutely. I mean, it's a great antibiotic. It's cheap. It's very effective, and it's great for gram negatives. And we do use it. And you say there's for aminoglycoside or for one of those, there's actually a test to see if that person is sensitive to that from a deafness point of view.
yeah.
Is that a genetic effect?
So the drug that I'm thinking of specifically is clopidogrel. Um, I don't know if that is in the same category, which has if the one has a genetic effect, I wouldn't be surprised if that has a genetic effect either, because as these things usually go, is everything has some level of combination of genetics and environment. So I can't say with certainty, but I wouldn't be surprised if there is a genetic connection between that
So,
and
so in your world, would you say that each baby should have a blood sample done when they're born? This is sent to a genetic lab, and there's a panel of the genome gets tested, and
yeah,
then each parent is issued with some sort of genetic profile, the varying risks, and they take that through life as almost like their road to health card. Every
yeah.
baby's got their little book that we use, but I mean that would be something that you would take with you like an ID card or something through your life, and this would be part of your medical history.
Yeah,
And
absolutely.
is that something that what you envisage maybe as something that almost like a little bit of a Mars project that maybe Elon Musk is dealing with? Is this something that
Past project. Yes.
you dealing with, or
Yeah.
I mean, how do you see
Yes.
this panning out from a
Yeah.
day-to-day clinical medicine point of view?
Yeah. Yeah. Well, so you don't even need to wait for them to be born. You can do it prenatally. You can take blood from the
Yeah,
mother and then determine things from that about the baby. Uh,
yeah.
but yeah, then so that would be essentially what it is. And it also, I would say, we'd have to look at sort of common disease and disorder predisposition things. Obviously, we're already looking at things like trisomy or Down syndrome and that type of thing. But
Yeah, yeah.
for instance, the BRCA genes that are related to cancer and cardiomyopathy genes, like MODY. So there are lots of genes that are linked to metabolic disorders and that type of thing. And so,
And we
and
can we
yeah,
do all of these with one test now? I mean, because absolutely. I mean, we see patients, and I mean, this is very relevant. I mean, BRCA is a very important gene, and but it's a challenge to deal with patients who have the potential for that. The implications for a specific individual with a BRCA gene is quite profound. And
yeah,
so, you to and I mean, the ethics would certainly need to be discussed at a level and at another level, and bringing in some heavyweight genetic ethicists along the
yeah,
way, because
genetic
just a
counselors.
simple, yeah, because I mean, for a woman who perceives her genetics to be normal, to be thrown with the BRCA gene sort of diagnosis, or I don't know how I would put it, but it's very difficult to deal with, because it has implications in what you're going to do with that information,
Yeah.
and so. But is that something that you can would test routinely? I mean, how do you select it? I mean, would cost be prohibitive in terms of selecting all those genes? Would it be like a tick box effect in terms of what you would do for those testing, or is it something that you can throw into a machine and coughs out whatever it is? I mean,
Yeah. Well, yeah. So BRCA specifically, if you use that example, it's it's one gene, so but it's all BRCA, but there are different variants. So there's BRCA1, and then there's well, I said there's one gene. So there are multiple genes, but they're still finite. So that would be a case where you can test for all of them, and that'll give you a fairly accurate risk score.
yeah,
So yeah, then that is essentially, so you get the type of test, the test for one deletion or insertion or one letter of the DNA that's wrong. So that would be, we call that a SNP, so a single nucleotide polymorphism. And then that's a extremely cheap and quick test. You just quickly do it, and then we see, okay, that letter is wrong. And this would be in cases like sickle cell anemia, you can diagnose like that. But that usually tends to be a diagnosis as well. So you have this, therefore you have that. Whereas a lot of these monogenic genes or panels, where you look at a bunch of genes, they not so directly diagnostic. So you can't say you have these variants and therefore you have this disorder, but we can look at your risk profile. And in the case of BRCA, once again, is if you have an exceptionally high risk profile, we can we can manage it from there. So and it's I understand completely why you ask, is because there have been cases of people being or getting the BRCA gene, that's the dangerous one, and then getting a mastectomy, but they
mm,
they didn't get a cancer diagnosis. And so yeah, in that I mean, that brings up so many ethical questions of now you've
mm,
gone and done a surgical treatment for a disorder that you only had a risk for. And that is a very difficult thing. And that is where the genetic counselor comes in and talks to patients. What is the risk, and how do you manage it? And
yeah.
and and therapists as well. So a genetic counselor is a little bit like a therapist in a lot of ways, but yeah, actually helping with the anxiety of knowing this information now in the first place. From the
Yeah, I
clinician.
mean,
Yeah, yeah, go for
yeah,
it.
look, I mean, in the end, this is going to be something that we're going to have to jump onto very quickly from a guideline point of view, because to simply do a newborn test and to lump a baby or newborn and a person, obviously, with this burden that they might have to carry from very early on in their lives could be quite a challenge.
Yeah,
Uh,
yeah,
Someone might not want to know that they have a BRCA gene that is very highly, um, likely to give them breast cancer.
yeah,
Um,
absolutely. I think,
um, it is very difficult. We've had patients who we've counseled. I think nearly everyone on the call who's in the industry, who's in gynae or in anything that leads to these sort of conversations with patients, would be, would agree that, this these conversations are important, and where patient goes with this knowledge or risk is interesting. And then obviously insurance,
mhm.
comes into the whole role.
Yeah, so
Um,
that's the big thing, and we'll talk a lot about that when we get to pharmacogenomics. Is well, we can't let the insurance companies have that knowledge because what if they can't they're not allowed to change the premiums for individuals, but if on a population level, let's say for example, the Afrikaner population has a higher prevalence of the BRCA gene in South Africa, could they regionally, geographically in South Africa make cancer life insurance? Would that be? But that's all stuff we can talk about with the ethics regarding pharmacogenomics and what we do with the data and who is allowed to have access to that data and that whole thing. But the best genetic test or the quickest genetic test that any clinician can do takes about 90 seconds and it doesn't involve any swabs or blood runs and it's just asking a lot of the same questions that people already ask, which is family history. So, is anyone in your family diagnosed with a similar disorder? Are there any people in your family with multiple conditions, primary conditions, so two cancers, or say a metabolic syndrome and something else, diabetes, for example? And are there any sudden or unexplained deaths in the family? So that's a survey. Those are verbal questions that you ask someone, but it's essentially a genetic test because what you're inferring from that is data about the heritability of these things, and and then from there you can once again the lights go off and this is probably monogenic or has a high penetrance as another genetic term there, and so you can tell or you can advise from there, right? So just a survey is already a form of a genetic test.
I love that, Chris. Actually, I think you've taken us very back to our second and third year of medicine, where we were told to sit down and ask the patient where the pain is and how it radiates, and then medical, as part of your history taking, is a family history. And how many of us still remember to take a family history? And that's very important. And so, and since you brought it up, I think it's very important that we just unpack that a little bit more. So, which of the aspects can you pointedly ask? So, diabetes, how do you ask the questions about diabetes? And then obviously all the other metabolic things, cardiovascular history in the family, and then the obvious ones. But I mean, can you maybe elaborate a little bit more on that? Because I think that is very useful and very interesting, and something that, has a direct influence on how we practice medicine day to day.
Yeah, yeah, and I mean that's a that's an exceptionally. It's almost like walking on eggshells sometimes if you're in the medical thing and you're talking to patients about these things because yeah, take diabetes as an exceptionally hard example as well because you inevitably will have to ask patients uncomfortable questions, um, and it that can be very difficult. But ultimately it's obviously for medical reasons, but yeah, I mean, if you're sitting there with the patient in front of you and you ask questions about family history, about say overweight people in the family and early deaths in the family and this type of thing, it can be, it's so interesting. I hear so often that patients come and then they're actually angry afterwards after seeing their doctor and they say, yeah, they asked me this question and what does this have to do with anything? And then if you know a little bit, you know why the doctor asked that. Um, And it usually is a case where, well, it's because you showed this symptom and they suspect it might be that thing. But a lot of these questions, to come full circle back to a patient, can feel like this is coming out of nowhere. What does this have to do with anything? And yeah, but that always comes down to the sort of the general clinical, good clinical practice. And
Yeah. Look, I mean, yeah, I mean, we see patients, menopausal patients, a lot, and a lot of what you're sitting there is trying to stratify risk and advise them.
yeah,
And going forward, it might be very useful to, and maybe I hope, I mean, I'm sure the physicians and the GPs are much better at this than us, but we maybe don't stratify the risk factors enough for patients, and it costs us for free, the
yeah.
family history.
I think it's
Yeah.
as important as taking blood pressure, asking about smoking, um, and like these are the questions that you ask to know when do you send someone to theater, when do you prescribe certain medications. I think it's on the
Mm.
same level of this should be a routine. You should actually ask this every time. um,
Yeah.
yeah.
Is there anything that we can ask our pregnant patients that could potentially prompt a more detailed search for a genetic disorder? Especially from a family history point of view, and that might prompt a more elaborate testing on the baby once it's born. Is there something that we might not think about?
Yeah, so that's an interesting example or question because, a lot of times a patient will come to you and they will say, this ran or this is something that runs in my family, or is there a risk that my baby might have this thing? But you won't, first of all, necessarily, humanly, you can't think of all the possible disorders that might be inherited, and it would be silly to ask specifically for everyone. So I think for that type of thing, it would be important to ask the patient sort of in general the are there any things that run in your family type of questions that might be a concern, right? And then, but that is something that's a little bit out of the domain of what the clinician can do right there on the spot. And if there is an example of someone who does have something that a clinician would suspect, okay, this sounds like it can be genetic. There are multiple people in the family that have this. This is not a normal phenotype, so you don't see this in the regular population. And it's also just on the one side of the family. So this seems to me like some sort of complex genetic link thing. Then from there I would say get a geneticist involved. So get a genetic consultant, get a scientific geneticist, or get a genetic counselor involved to have a look at this. And if it is indeed genetic related, then they can. I think that person should probably be the person that actually speaks to the patient from that point onwards about it as well. Um,
Okay.
of course, there are more common things, but the common things are already tested for. So newborn screening, reproductive screening, these things like basic family history cascades, these are already common practice in most places. Um, yeah, yeah.
Yeah. I mean, so can we pivot to the NIPT, which I think is a very important test, and it's obviously something that has become very deeply ingrained in the way we screen patients. Is there a way of making it more accurate? Because I think for us who offer it to patients, the fact that there is still that chance that it might not be 100% accurate, there's still that fractional um, result that might not be exactly accurate, and that kind of still prompts the more invasive testing. So, I
Yeah.
mean, are there ways that you geneticists can make that test a little bit better?
It's very
Or
interesting that you asked that. So there's some big things happening in the UK right now, where as part of their national funding, they've actually made NIPT part of the standard testing that anyone can get or opt in for, and insurance companies pay for it. And then there is actually a test that is being rolled out in some places, a PGT test, which actually is a little bit more accurate than the NIPT, or so it
what
seems
does it
from.
stand for? What does PGT stand for?
It evades me right now. Um, Yeah,
Okay, that's fine.
if it evades me right now, but it does give you a little bit more of a broader idea than the NIPT.
So it's
And
also from the maternal blood, but it's a slightly different genetic test.
yeah,
Okay.
it's a slightly different genetic test, and it gives you more information. Um, and yeah, so that looks very promising, and it's due to the advancements in genetic screening technology in general. Uh,
It's
the
also for Downs, the trisomy 21, or does
Yeah,
it capture the other ones like the Edward
yeah,
and the Task?
Edward, Prader-Willi, Angelman, all of them. So anything
Okay,
that's
really? So it
that
actually picks up.
yeah, 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 yeah. So yeah, chromosome 13, 18, 21. So they look at any chromosomal aberration, it'll pick up. And yeah, so it's actually very interesting that you asked specifically about the NIPT because the people are looking at actually moving away from NIPT to more accurate tests because NIPT is also expensive, especially in countries like South Africa. Yeah. Yeah.
Is it possible to pick up micro deletions like the 22Qs and stuff on the maternal tests, maternal bloods, or because I mean there is still an indication for that in some patients, and that's where you then have to bring in the more invasive coronary sampling and amnio, etc.
Yeah.
Um,
You can pick
do you
up
think
a
we'd eventually
deletion.
be able to move away?
Yeah.
Sorry, do you think we'd be able to move away completely from the invasive testing?
Um, it depends on what level of invasion you're talking about. So because you can pick up a microdeletion with a PCR test. Um, but for that you would need to have taken a swab of saliva at the very least, or have drawn some blood. I mean, you can get DNA from any biological matter. You can, if it's less invasive, you can do it prenatally, so you can do it with the mothers. You can even do
Okay.
it, but so there are examples to make it less invasive. But I think of where we are technologically right now, it's difficult to do a genetic test without biological matter. So you ultimately will have to take something from the patient or the baby in this case.
So
Uh,
yeah, so I mean, what I'm talking about here really is that obviously getting a sample of blood from the mother is very easy, but the minute you need to actually get some fetal DNA, you're then down to doing the amniocentesis or the current venous sampling, which does
yeah,
bring in some risk to the baby. And so if you're able to do this in a non-invasive way, as with the NIPT, which is essentially non-invasive prenatal testing,
yeah.
um, you know, so are we quite close to getting to the point of where some of these more rare things we can actually possibly even do with a sort of a NIPT type system?
Yeah, a prenatal test. Absolutely. Absolutely. You can definitely, because there's you can the reason it works is essentially because you can find the baby's DNA um, as well in the system. So yeah, it's actually quite a basic technical reason for why it works. And so yeah, absolutely, you can do all sorts of prenatal tests similar to the NIPT where you don't have to take anything from the fetus. You can get what you need from the mother. And
Yeah.
this is less a case of of the technology not being able to do it, but the application of it being limited. So we are only doing it in a few examples, but where we can actually apply it is quite broad. But as you would know, these regulatory approvals to get a clinical process approved, it takes long, and especially in cases where it's not necessarily something that's immediately life-threatening. So and that's the thing with genetic screening is
Mm.
most of the time you're taking healthy populations. So to justify a new therapeutic method where the population is not directly inflicted with a disorder or disease is difficult. It's actually quite a difficult thing to um, get approved, but it is possible.
So yeah, so and in my previous discussions with you, one of the more exciting, very practical sides of this conversation is the fact that there are very real ways of making the non-invasive testing more accessible and cheaper.
Yeah.
Did you want to talk about this a little bit? Since it does cover a lot and it might potentially be something very useful for the patients who can't really afford this, ranging from the state patients all the way through to private practice patients. So have you got some thoughts about how we could possibly do that?
Yeah, I mean, a lot of these things come down to logistics. So if for instance, if you can cut out the middleman, essentially, um,
Mm.
especially in cases like South Africa, where some of these tests are being shipped overseas to go do the test there, and then we get the data back from there. But it's unnecessary. We can do, and above and beyond the fact, so NIPT is one example where we do have some labs, but a lot of it gets outsourced. And especially if you're screening for things that are simple, monogenic, or even single variant, so single letter microdeletions, for instance,
Yeah.
you why are we doing an expensive test for that? You can do rapid PCRs, like similar to the ones they did for the COVID tests, where you're looking at you take primers and you take a little sample and you look at this very, very, very specific set of DNA. And so you can make it cheaper in that way by, depending on what question you ask and what you want answered. If you don't need to look at a whole array of things, then it's unnecessary to do a whole gene panel. Right? You can look at a specific SNP, for instance, single nucleotide polymorphism. Yeah, but that and the advantage. So a lot of the other thing, of course, is a lot of these things are almost bound by tradition. So NIPT, for instance, works. And so people are hesitant to move away from what works, even though the technology has since improved. Yeah,
Well, Chris, I mean, there's a lot at stake. So you're seeing
yeah,
a patient, maybe, someone who's quite anxious with a partner. Maybe they want to know, are they at risk? Do they have, and you spend a lot of time with the data, with testing, with all the research into NIPT, and then they elect to go for that. And then you give them the result, and that result is based on some criteria and protocols, and you walk away from that. But then we bring in something like the PGT, which is a completely foreign test. And with that brings more anxiety to us as clinicians because you don't exactly know how to discuss those with patients. And then you get a positive result. How do you talk to your patients about that? So I think, if it comes down to having something that is more accessible and obviously less costly,
mm,
with that, there would have to be a package of information that you can share with your patients and how you actually would then, roll it out with them.
yeah. I think where that begins, and that's what we spoke about at the beginning with the connection between scientists and clinicians, is scientists need to make these things. So scientists need to make these things easy to understand for the clinician, and the clinician needs to make these things easy to understand for the patient. And so that at every level that you're communicating at a level that makes sense for that person. So it doesn't help, for instance, you go to a patient and you tell them your hemochromatosis is caused by a BRCA1 variant, and this is an HFE example of a single gene variant. They're going to look at you with big eyes and think, what are you talking about? And so, but you need
We're
to.
also going to look at you like that. So we'll stop speaking.
So,
But
so yeah, and so I think from the science perspective, you need to make it simple and say, okay, this is a single gene. This is a very focused test. We only want to know one thing. We want to know this is this BRCA, um, and therefore it's linked to this type of breast cancer. It's very precise. That's an easy test. That's a quick test. In fact, you can, with a little bit of training, you can probably, and the right tools like centrifuges, you can probably do that in practice, in your practice. Um, and yeah, so that's the one thing. So splitting, okay, that simple test. Then the second one is the targeted panel. So this is cancer, but we don't know which one. So let's send in a panel that tests for BRCA1, BRCA2, Lynch, a bunch of other genes, or in the case of heart complications, cardiomyopathy panels, or epilepsy panels, or FH panels. There are lots of arrays. So it looks at a bunch of different genes. And so this is the case where the phenotype is clear, the phenotype being the physical manifestation, the symptoms that you can see, but it's possible that there are multiple genes at play, right?
yeah,
And each of those usually come with their own guidelines. So whether it's cancer psychiatrically related. Um, so yeah, so single gene targeted panel, and then the third example is like a whole genome or a whole exome sequencing. This is where you look at all of the letters and all of the letters and the grammatical um, additions to these letters, and these are the case where it's highly complex, it's syndromic, it's undiagnosed, the even the phenotype isn't clear. You have lots of variants of uncertain significance, and this is always going to be the case where you actually outsource it to, or at the very least, you get a geneticist involved. Um, so so it's interesting. So you mentioned the NIPT earlier. So the NIPT is a non-invasive test that uses the cell-free fetal DNA to the maternal blood DNA. Super sensitive and very specific, and it looks at I think chromosome 21, 18, and 13. But but and then you can, once you have that sort of screening, you can do the amniocentesis that you mentioned. So, but the important thing is, what do you actually say to the patient so that they can know how to die, or how to, what should they do with this information? Because I think even that is a
Yeah.
is a yeah, it's a yeah, it's the connection between the scientist, the clinician, and the patient is so, I don't want to use the word fragile, but and I think there's a massive demand for having people who do the complex genetics, right? So you look at the full genome and also do the gene panels, and then take that information and digest it into a format that the clinician gets and sees, oh, okay, this means this clinically. I understand the phenotype of this. And then we need a system, maybe AI can help us with that, where we take that information that the clinician has, and how do we simplify it again? Another level of simplification for the patient to actually walk away and feel like they can do something about this, or they know what to do from this, or what this means. And yeah, and so you and you need ultimately, you do need to do pre-test counseling with these patients as well. So you say things like, this test might find something that is disease causing, and where we know what to do, we're going to do that. But it might be something that we don't understand yet, or if we find nothing, we can't necessarily even then rule out all genetic or environmental factors, because there are still variants and things that we don't know the significance on. So yeah, it all comes back down to the ethics of it all as well. Ethics in communication between the levels. Yeah.
So yeah, look, I mean, I think people might be wondering why we actually even bothering to have these conversations, but I mean, it's for me, it's it's the new paradigm of medicine, and I think that we need to understand how all the technologies will intersect with what we are going to be doing on a day-to-day basis. But I mean, there's no doubt about it that we will be able to understand a lot more about a disease process and about the patient's specific individual risks and the profile. And that's where we bring in the whole term of precision medicine. But at this very point in time, we have this precision medicine technology, but we all know that there's a massive surge in our ability to process knowledge and to process information now with AI.
Yeah.
And I suppose ultimately there would be nothing wrong with having an automated type AI prompt or probe or um, counselor as well. I mean, we've all sat with ChatGPT and tested with all sorts of tests and questions, and come up with information which is good. So ultimately, I don't really think that we'd maybe be as heavily reliant on a person or a human type
Yeah.
genetic counselor. I mean, this is something that would be processed very nicely through an AI type system.
What's an analogy that I like to use is they always used to say they always used to say that you wouldn't have your calculator with you in your pocket at all times. And then of course all of us have a cell phone with us these days, and we do have our calculator with us. And now the sort of next step that we're seeing now with AI with that is You you even now in universities you have to memorize large amounts of data, and in med school as well you need to remember all of the syndromes and symptoms and so
Yeah.
forth. But we having the fact equivalent of a calculator with us, and and ChatGPT or AI, general AI, with all of its caveats and mistakes and taking things with a pinch of salt, is essentially like having a little professor in your pocket. And so when in doubt, it's not a bad idea to start there, right? Don't end there, right? You do proper research as well, but it's really not. And when it comes to pure data and information that we've already synthesized and information that we've done this test, we know these genetic factors about these 10,000 genes, right?
Mm.
Then it's not, it makes sense to use machine learning to simplify that. It makes sense to use AI to make that into a format, information wise, that can be understood by the clinician and the patient and the scientist.
Absolutely, so I mean, and that's this is actually where AI, I believe, would really come into its own because having used AI extensively for different things that I've been trying to do, I've started to see it reaches its kind of almost terminal velocity or ceiling, and you kind of feel like I'm sure there's more out there, but it doesn't really get any further with things. But this it wouldn't really need to think more broadly than we would program it to do, and or teach it. And I think it would be important for us to do just good hardcore scientific and robust research into it, and really make sure that it was functioning very well. So
Yeah,
that is probably a new area of research in clinical medicine as
yeah.
to how we can use AI to assist us
Clinical
as
grade
that.
AI.
Yeah, yeah, absolutely. Like the clinical grade silicone we've been talking about this week
Yeah,
as well.
yeah,
Absolutely, and that analogy is actually fantastic, and rather than making something like that up. So,
yeah.
um, yeah. So I mean, there's so many aspects to this. Chris, there haven't been any questions. I think you're kind of stunning a few people, yeah. But I mean, we'd love to have some interaction. I mean, it's been wonderful that most people have stayed on. Please ask a question if you want to ask a verbal question. We can even unmute you.
Yeah.
Um, but yeah, it's been wonderful. And there are some fetal medicine people on here. There's some fertility experts on here. So absolutely great to have you guys on board. And these are the things where, we um, are seeing in day-to-day clinical medicine. But obviously, also trying to understand where to draw the line. Some of the stuff you could do very early prenatally too, and we've been talking about designer babies over years and things like that. But that's something
Yeah.
else that is on a different
But
world.
that's a great topic for the future webinar as well, is that the whole field of designer babies and gene therapy and genetic engineering and how that all uh, gets tied into medicine and what do we do with that. So that's definitely something that we can touch on in the future. Um,
But
and
Chris, we've been hearing about this. I mean, this stuff has been part of science fiction and things for decades. But
mm,
for the first time, this is now kind of at our fingertips, and this whole intersection of the accessibility and the cost-effective way in which you can now do genetic testing.
yeah,
That is really the exciting part.
just
And
last week,
as
sorry.
doctors,
Oops.
yeah, carry on. Yeah,
Yeah, sorry, no, I interrupted. So just last week they did a gene therapy on a child and cured, I forget now if it was blindness or deafness, but one one of the two. But yeah, and so these have been things that have been in conversation for the longest time. But I, science fiction ultimately eventually becomes science. The
yeah,
fiction part falls away with time. So yeah,
yeah, yeah. No, that's great.
yeah,
Yeah, look, I mean, we're coming to the end of the hour nearly, but I
yeah,
mean, it's wonderful that we've had so many people on, and I mean, this is really there was just an opening conversation about the whole realm of where we are, and it's this does intersect a lot with what you do on an obstetrics and gynecology level, but this is broad in terms of how it works in psychiatry, neuroscience, orthopedics, genetic, and medicine. the metabolic and cardiovascular diseases are huge, and how we risk profile those, exercise medicine,
Oh yeah,
uh,
definitely.
and then something that I'm also very keen to see how this affects the nutritional aspects of our day-to-day lives, and how we can advise patients appropriately in terms of what they can do from a dietary point of view. Some and I was just thinking the other day, I was speaking to many years ago, one of my mates' dads, who started talking to me about the blood type diet. And we thought that that was a bit mad, but in the end of the day, that was probably one of the earliest ways of looking at nutrigenomics.
Yeah.
Your O type, your O, your AB, you must rather eat that, rather eat that. I mean, but it actually really has a lot of science inside that, isn't it?
Yeah, and well, the two-sided coin there. So the especially the blood time one has some questionable science there, some pseudoscience related to it as well. So that's always the what's the saying, separating the wheat from the chaff. So you have to the fiction from the science. The but yeah, I agree. That it was one of the early sort of examples of trying to determine almost genetically what would be a good diet. And nutrigenomics is a massive rising field now, and so is the
Yeah,
diet genetics and exercise genetics, and yeah, so these genetic related things that we can test for now is just we're at the precipice of where we're able to really, really, really positively affect a lot of people's lives, and in ways that we've actually been doing for as long as we've been around, the exercise and nutrition and so forth is, but we have a
absolutely.
massive new tool at our disposal. Yeah, yeah,
Yeah, it's great. Anyway, that was really just, I mean, this was really an opening conversation of many that we'll be having. We want to run these webinars on a weekly basis.
yeah.
At this time, we will want to bring in some guest speakers, guest conversationalists. Chris, what else did you have in mind, and just to really from the information point of view for those people who joined us tonight?
Oh yeah. So I think just very basically look forward to some interesting talks. We spoke about a few potential future topics from pharmacogenomics to genetic testing, and or gene editing. We spoke about genetic testing tonight. And I think I had some neuroscience topics and some synthetic biology is another thing where we these days we can print almost working organs with a 3D printer and all sorts of exciting beyond just the scope of genetics. Genetics is my field, but we'll extend to laser regeneration and all aspects of translational medicine. But I think, yeah, in a
And
nutshell,
we'll
look forward. Yeah.
yeah, I look forward to that. And hopefully, with some of those topics that are kind of really groundbreaking and new, we will try and find someone who would be an expert in that to try and bring in that. So it's
Yes,
very exciting. So we
absolutely.
look
Yeah.
forward to that. It's
Yeah.
great. But well, I mean, it's coming to the end of the hour as we now embark on a festive season. But thanks to all of you for joining. Thanks to Chris for your initiative and for starting this webinar series. And we do look forward to starting again. I think we'll start again on the 14th of January. Or
Let's do it.
what?
Yeah,
Yeah,
that's perfect. Let's do it. 14th of
yeah.
January, right here.
That is
Yeah.
Wednesday, I think. Is it? Can we just check on that?
Yes, absolutely. The 14th is a Wednesday.
Yeah. Okay, and that'll be the same time, 6 o'clock. We'll see you there. And thanks to all of you for joining. It's been a wonderful conversation. And yeah, enjoy the festive season to all of you.
Yeah. Yeah.
Thank you, Chris.
All right. Thank you so much, Stephen. Cheerio.
Bye.
Good night.
Bye.